Hey everyone, Prof G here, and today we're going to talk about the chief complaint and the history of present illness. To me, the patient encounter course is one of those courses that is highly underrated, meaning that it is so important when you're going out and seeing patients. And I think that if you don't have a good sense of how to ask patients questions, it's going to be extremely difficult for you to gather a good history and to make good clinical decisions. So it's something that you cannot afford to overlook. So today, what I wanted to go over in part of a series of lectures that I want to do is the chief complaint and the HPI, which in my opinion is the bread and butter of gathering a history and the most important part of your history in general. So today what I wanted to do is show you my cheat sheet and go through kind of some of the things that I do in my approach to doing a HPI. Now, of course, I worked emergency medicine for a very long time and now I do pediatrics. So the version of an HPI that I do now and what I have done in the past is much abbreviated to what I'm going to show you and talk to you about today. But I think it is really important to understand kind of the why behind why you're asking these questions. Because if you understand why you're asking the questions, you'll understand when to ask which questions. So without talking your ear off, let's go ahead and get started looking at this cheat sheet. All right, so first of all, before you enter the room, the most important thing you need to do is review the patient information. In most EMR systems, electronic medical record systems, you will have a chief complaint, which is why the patient is coming in, usually in their own words. And you'll also have their past medical history, whether it be prior visits, any type of history that they might have inputted before you're seeing them. It's just really good to have a grasp of who your patient is before you walk in the door blind. So most important, name, age, chief complaint, vital signs are what are going to be provided to you for your practical examination. You'll want to make note, at least in your head, maybe on a little side cheat sheet that you have, of any abnormal vital signs. Vital signs are vital. And so we need to be able to recognize what is normal, what is abnormal. And that kind of clues me in. It heightens my level of suspicion if those vital signs are altered. And you're going to start forming a differential very quickly on. We are trained medical detectives. And what this means is we use all of the knowledge that we gain to apply to the patient's problem to be able to figure out what exactly is going on. So a clinician's brain is going to start forming that differential diagnosis from the very get-go. From the minute I see that chief complaint, those vital signs, I'm going to start forming that differential. It becomes natural. But for y'all that are just starting, you want to start intentionally doing these things, okay? So what I like to do before I go in to see the patient, especially here in your practical setting, in your patient encounter course, is you need to write down some sort of skeleton of the questions that you're about to ask the patient. Now, for this section, we're talking about the chief complaint, which is already being given to you. Remember that you have a set list of chief complaints that we can ask you about on your practical. And then after that, we are going to want to write down the skeleton or kind of something that can help clue us in to the history of present illness, which in my case, I really like the mnemonic old carts. I'm not sure what you've learned in the past. There's also other mnemonics like locates or Socrates. There's several of them. I'm going to show you my old carts method because I think I've figured out a way to chronologically or kind of systematically hit all of those points in the HPI. And if you like it, great. If you don't, stick with what you know. But the most important thing for you is to have a method. You know, you want to be consistent when you're walking in, no matter the chief complaint, so that you don't forget vital information. Okay, so after we write this skeleton down, you're going to be given a minute before you walk into your practical examination. So you want to get really good at making your template concise and consistent. You're going to knock on the door and wash your hands. This can be, simulated. No need to take a precious time in your practical exam to actually wash your hands. You're going to introduce yourself and you're going to ask for consent of the patient. And this can be something as simple as, "Hi, I am PA Gonzalez or PA student and I'm a physician assistant student with the University of Texas, Rio Grande Valley, or UTRGV, and I'm here to see you today and ask you a few questions. Is that okay? They say yes, you proceed on. Before we get started, I'm going to go ahead and wash my hands. Can I verify your name and date of birth? Great. And then you're going to start with open-ended questions first. Sometimes I gather some of my best history with open-ended questions. And I've always been taught that there are no such thing as poor historians, only poor history takers. Uh, I'm still on the fence whether I believe that 100% because there are some pretty bad historians, but we still have to do our best job to get that history out of our patient, make them feel comfortable enough to talk to us. So you start with open-ended questions. Open-ended questions include can you tell me what brought you in today? Or can you tell me more about, and then insert the chief complaint. I see that you're here for a fever. Can you tell me more about that? It's giving the patient the opportunity to tell their story. They probably have already been kind of going through it in their own head as they've been waiting for you to enter their patient room. So let them talk and try not to interrupt them. Let them tell you the most important things that they can think of first. As they're telling you this, remember you have your little template here, your little cheat sheet. You're going to start filling in those gaps. If they tell you when it started, you'll fill in that onset gap. If they tell you that it's a excruciating, throbbing pain, fill that in the character, and then work your way from what they tell you. Now, tip. This is a tip, very important. In your practical examination, we have trained your simulated patients not to give you a lot of information when you ask open-ended questions. Why? Because we want to force you to ask those questions. We want to see if you know all of the important questions to ask. So in the real world, great, open-ended questions are awesome. In practical world, might not get you very far. You might still need to go through your mnemonic one by one. Just a side tip. All right, so you're going to start forming that differential, continue forming that as you go along. Once you ask those open-ended questions, I like to follow up every open-ended question with, can you tell me more about that? We can kind of dig for more information. Once you've gotten everything out of your open-ended questions, that's when you start targeting the closed ended questions. And this is where I want to go through my mnemonic, which is OLDCARTS. So OLDCARTS. And I'm going to go one by one and show you what I do and kind of the method behind my mnemonic. So, like I said, whichever mnemonic you choose to use is great. You stick with it. This might also help you even if you don't use OLDCARTS because it can kind of tell you the importance behind those characters like onset or duration or things like that. So let's start with O. O in my mnemonic stands for onset. In the traditional OLDCARTS mnemonic, O is onset, D is duration. But for me, when I ask timing questions, timing means, when things started, kind of getting a grasp of whether this is acute or chronic, knowing if it's constant or if it comes and goes. This is all timing. So I like to put all of my timing questions all together so that I don't miss pieces. So my onset is actually onset/timing. Okay. So I want to ask, when did it start? This is going to help me gauge, is this something new or something that is chronic, right? If it started and it is constant or intermittent, that's going to help guide your next questions, right? So if it's constant, when it started to now, that means it's been going on for that period of time. If it's intermittent or it comes and goes, you're going to want to ask then more questions. The frequency, how often have you had this? Have you only had one episode? How many episodes have you had? And how long have the episodes been? And how much time has there been between the episodes? So those are all really important questions to ask. And then another important questions to ask is, has this happened to you before in the past? So it's still part of timing. And another thing to ask is why today? So if it started a week ago and they're coming in today, kind of not in a rude way, of course, in a professional way, you need to ask, is it worsening, or what brought you in today? Okay. And that's my onset. Okay. Onset/timing. Location on my mnemonic is location times 2, or location squared, I guess. I don't know. That's just what I put on there. But basically, what I mean by this is I want to know the location, which is sort of the environment or setting location. And I also want to know location of where exactly on the patient's body is this problem. So let's start with location on the body. So I like to ask my patients, can you point with one finger where the pain is? And a lot of times I get like this. They're like, oh, it's right here, and they point to their whole abdomen. But just try to really pinpoint the exact location as best as you can, because sometimes that could really narrow down your differential diagnosis. Um, Also, you want to know if this is a localized pain. So can you point to that right lower quadrant of the abdomen, or is it diffuse? Is it all over? Right? That's really important as well. And also, you want to ask about radiation of the pain. So does the pain travel? This is a good opportunity to give you another tip. My tip for you is you should address the patient. Don't treat them like a kindergartner, but try to gauge the level of intelligence of your patient early on so that you know what type of terminology to use with them. If I'm seeing someone, the average patient, I'm going to try to speak in terms that anyone will understand. And what I mean by this is, instead of asking does the pain radiate, you can ask them, does the pain travel anywhere else? Right? You can use words or vocabulary that you're confident that all types of patients will understand. Next up is location slash setting slash environment. So this is the other location, right? Where were you when this started, or what were you doing when this started? Was it at rest, or were you active? Trauma? Is there trauma associated? Did you recently travel somewhere? Travel is also a question in the past medical history, but sometimes you have to ask these questions up front. By the time I get through my HPI, I should have a really, really good idea of what's going on with my patient. I should not have to wait until the past medical history, the review of systems, or the family social history to get a better picture. I'm going to ask all the important things up front, even if it means grabbing some pieces out of the other parts of my history. Okay. Another one I like to ask in this context is sit contacts. Okay. And then if there's anything new, now anything new is not something I would ask just any patient. It's really tailored to the chief complaint. So if they come in for a dermatological issue like a rash, right? I'm going to ask them, have you used anything new? Any new medications, food, soaps, any new activities? I'm not saying in this, I guess, template or a cheat sheet, I'm not saying you have to ask every single one of these for every single patient. You have to get good at knowing what's important for each chief complaint. And I'll talk to you a little bit more about that towards the end of this lecture. Okay. So, and then I like to ask about daycare for pediatrics, because daycare, they're little petri dishes. They got lots of germs passing around there in the daycare. All right. So moving on to the D. Now, this is my version of this, because in the original old cards, the D is duration. But in mine, I really hone in on my chief complaint and my disease specific questions. And that's what I use my D for. It's a place filler for me. But I'm really going to use this area to think, or to just remind myself to think about things that are important to whatever chief complaint I'm asking about. Example, if I have a patient that comes in with a headache as their chief complaint, one thing that I absolutely cannot forget to ask is this the worst headache of your life? Okay, because that's very specific for a life-threatening type of headache. Similar would be if a patient came in with lower back pain, severe lower back pain. I want to make sure to ask them, do you have any bowel or bladder incontinence? Because that will help me rule out something that's really, really bad, right? So this is a place filler, and it's going to be specific to your chief complaint. One other thing I like to use this spot for is when I need to pull in some sort of historical component from my other histories. For instance, let's say I have a female with abdominal pain. I'm going to need to ask them about their period. I want to know when it is. I want to see if they have a chance of being pregnant, right? But last menstrual period is not until the women's history, in the past medical or social history. So I need to ask that now. I don't want to wait till then. So this is a place where I would put it in. That's my example. Okay. It's just a suggestion. It's just for you to make sure you're not forgetting anything. That's what the mnemonic is intended for. Okay. Let's move on to character. Character is um, it's different for every chief complaint. Now, in my opinion, pain related chief complaints are the easiest to assess because everybody understands pain. It's a little less subjective than something like diarrhea or a cough or fever. It's like, how do you characterize that? It's very difficult. It's more difficult to characterize a fever than it is to characterize chest pain. Okay. So in general, quality. So the quality of the pain is asking the patient to describe it, and I often allow the patient to give me their own words first. I don't like to put ideas into their head, so I like to ask them like, "How would you characterize your pain?" or "How does the pain feel to you?" And then from there, I wait, I pause. Okay. Sometimes we get a little impatient. We want to just like, is it sharp? Is it dull? Is it achy? Is it? And I feel like sometimes they're like, okay, dad, it's sharp. They kind of start panicking a little bit and they just go with whatever the first thing is that you offer them. So give them a chance to tell you. If they don't understand what you're asking, and often patients don't, offer descriptive words as kind of options, like a multiple choice question, right? So pain, sharp, dull, stabbing, cramping, throbbing, pressure. Bleh. Okay, and that's description for pain. Now, if it's a cough, you want to dry or wet, right? So there's other characteristics that you can ask about, other qualities of symptoms. I like to, once I'm talking about the pain itself, I like to ask about the pain scale at this time. So I will ask if it's between 1 and 10, 1 being the least amount of pain, 10 being the most pain you can ever imagine. Where is your pain at this moment? Moving down to the other types of chief complaints. So remember, pain is not the only type of chief complaint we see. So examples of this would be like diarrhea. So the character of diarrhea would be the color, the consistency, the blood, the mucus. And I know it's kind of graphic, but you really want to get as much information as you can out of your patient. Um, Also, rash, ask them to describe it. Most of the time, you're going to be able to see it yourself. So that's not too much, but they can describe it. If maybe it came and went, what did it look like, right? Another thing besides quality, also like quantity, and by that I mean how many episodes. You might have already covered the how many episodes up in the timing, maybe, but this is a good reminder of that. Okay. A in my mnemonic is aggravating factors. So the easy way to ask this to your patients is there anything that makes it worse? And I like to stop, pause. I don't like to offer my patients multiple choice questions because I feel like they choose it and they don't think for themselves. So I like to try to gain it fresh. Okay. So is there anything that makes it better? Pause. And if they're not sure, like, what do you mean? Then you can say, if you tried any medications, are there any positions that make you feel better? Any activity? And I like to start with, I'm sorry, make it worse. Excuse me. Anything that makes it worse. Position, activity. I like to start with making it worse because once I go to making it better, then I follow that up with treatments. So the follow up to that is anything that makes it better. If they tell you something, let's say they say, laying down on my back makes it feel better. Okay, tell me a little more about that. Well, when I lay on this certain position, I feel better. Okay, is there anything else that makes it better? Always circle back and ask again until they tell you no, so that you don't miss anything. And then making it better, I like to start with, is there anything that makes it better or what makes it better? Because if you ask them if they've tried anything to make it better, that kind of cuts out like positions or certain activities, and they might think just straight up treatments like what you can get over the counter. So then moving to treatments, these are going to be not just medications, but any type of treatment like ice for a knee pain or, over the counter remedies, home remedies, teas, all sorts of stuff, herbal medication. You never know. So I like to start, have you tried anything for the medication, any treatments? And they might see medications. If they give you a medicine, like let's say they said, oh, I took some Tylenol. Okay, what was the strength of the medication? How much did you take? And how often have you taken it? And does it work? Okay, you want to follow that up with any medications. If it's a medication that sounds prescribed, we live down here in South Texas where patients can go across to Mexico and get pretty much anything. So you want to ask them, like, have you seen someone for this recently? Have you seen someone? Did you get a prescription for this? Is this someone else's prescription? I mean, don't ask like that, but that's what I'm thinking. Um, Other things, home remedies, like I mentioned, anything really. And then any recent visits. So, have they recently been to the doctor? Have they already been seen for this? Any recent ER visits? So you want to kind of gauge, is this brand new that you're treating from scratch, or did they already have one opinion? They're getting another. I don't know. You just kind of have to gauge that. And then my S is kind of two-part. The traditional S on old cards is severity, and that's referring to the pain scale that we talked about earlier. Um, if you did not ask it up in the character, remember I like to ask it up here in character when I'm talking about the pain itself. If you forget, this is another reminder. Oh, I need to talk about the pain scale. The pain scale is it says 1 to 10 here on this cheat sheet. It could technically be 0 to 10. If they have zero pain, then it's a zero, right? One thing that I used to really focus on when I was in the ER is this 10 out of 10 pain. In my opinion, a 10 out of 10 pain is like the worst pain you could ever imagine, because I can tell you 100% I've never felt a 10 out of 10 pain. It's very, very subjective. My main tip for you is do not focus too much on it. Don't make them feel bad. It's their perspective, and everyone tolerates pain differently. So just write it down, take it for what it is. But I think there are other indicators that help you to understand how much pain a patient is in, right? There are visual cues or things that you can pick up on that maybe can correlate with the subjective rating that they're giving you. So take it with a grain of salt, but also don't judge people for the pain skill that they pick. Okay. Um, so that's the first part. That's my severity. My second part of S is asking the extra symptoms. So in the traditional locates model, the other symptoms, as you can see here, is the second thing that you ask. I do not like to ask for extra symptoms early on in my encounter, and I'll give you my reason. Um, Most patients that come into the clinic have more than one chief complaint. They have a cough with fever. They have sneezing and a cough. They have a runny nose. They have a cough. They have abdominal pain. They have a bunch, nausea, vomiting. They might have 3, 4, 5 chief complaints. I like to try to tackle the main one first and then wait till the end after I've gathered the information on that to ask about the extra symptoms. And that's why I like to put it at the end, because then I can ask them about the important associated symptoms based on the chief complaint. Let me give you an example. If someone's coming in with chest pain, okay, chest pain, I'm already starting to form my differential. I'm thinking heart attack, costochondritis, pericarditis, pneumonia. There's a bunch of things that it could be, right? And so, related to what I'm thinking it could be, I need to ask extra symptoms to help me figure out what it is. So, with a chest pain patient, I certainly wouldn't ask them if their little toe hurts or if it's swollen, right? That doesn't correlate. I probably wouldn't ask them if it burns when they pee, right? That doesn't really make sense for that chief complaint. What I would ask them is, are you having any diaphoresis or sweating? Do you have any shortness of breath related to it? Do you have any nausea or vomiting? Any swelling in your extremities? So you'll see that the chief complaint helps dictate what extra symptoms I want to ask. And these are the same symptoms that you'll ask in the review of systems later on in the history, but you need to ask the important and pertinent symptoms early in your HPI that are related to your chief complaint. And this might be a little hard for you because you haven't had clinical medicine yet to help you tie those things together. But what I would recommend is, and this is a tip that I was going to tell you earlier, but I'm saving it for the end, is that for each chief complaint that is on your practical examination, I would create a little cheat sheet or a little script that helps me remember at least a few of those important symptoms that I need to ask about. And I have a sample of this that I can get to y'all. Okay. So that being said, we've gone through my version of old carts. Before I get to the summarization and stuff, I wanted to show you really briefly locates, because that might be what you've been taught. Okay. So locates, the location of the symptom is first. The second O is for the associated symptoms. C is a characteristic. Okay. A is alleviating factors and aggravating factors. T is for timing, so duration, frequency, similar to my O. E is environment, which is similar to my L, one of my L's, and then S is severity, which I have in my S or in my C. So you can see that there's a lot of overlap here. Mine just has a little more clues, a little bit more indicators, and I like the order of old carts better than locates. Okay, again, to each their own. This is just my method. After I've gathered my HPI, I'd like to give the patient another opportunity to add anything that they would like to share. So, is there anything else you'd like to share with me? And then I'd like to summarize the visit for them. So I'm going to go ahead and summarize what you've told me, and you can let me know if I'm leaving anything out or if I misunderstood anything. And then you're going to quickly detail the main points of what they've shared with you. And that's why it's important to have your cheat sheet, your little notes, because you can kind of, I don't expect you to read it word for word, but you can help remind yourself of the answers that they shared with you. After you've summarized and you've clarified everything, then you'll thank the patient and inform them that you'll relay whatever you've discussed with them with your supervising clinician, whether it be an MD or PA. And that ends the history of present illness portion of the history, which again I think is the most important thing. Before we go, I want to share a few other quick tips for success. I've been sharing them kind of throughout here. Hopefully you like it. If you like it, you can give me a thumbs up. That would be great. If not, you can post in the comments any questions that you have about taking a good history. Okay, I have a little over 17 years of experience taking history, not including when I learned in PA school, which was a few more than that. But I hope this has been helpful so far. My tips for success are practice, practice, practice. Get your mom, get your sister, get your brother, get whoever you can get to ask them questions. Everybody that you know has had some sort of encounter with a clinician. Okay, so they know kind of the routine of it. They might not know how to answer all the questions for your symptoms, but that's where AI can come in. Okay, AI can be your big friend. You can have ChatGPT or whichever AI chatbot you like to use create a little script for your patient. In other words, if you have a chief complaint of, let's say, abdominal pain, you can have your patient, your sibling, or whoever it is that you're having help you out, create a plugin. Give me a quick script for cholecystitis, right? So gallbladder attack, and they can create a quick script for them to follow so that they can give you the correct answers for you to come up with the diagnosis. Okay, at this point, you coming up with the diagnosis is not the top priority. Right now, it's just making sure not to forget any key questions that you need to ask your patient. Okay. Um, Whichever mnemonic you pick, whether it's my old carts or locates or whatever, just stick with it. Okay. Stick with it and learn it really, really well so that you do not forget anything when it comes down to practical time. Because we all know practical situations, we get a little bit nervous, and that can kind of give us this mind fog, right? So we want to make sure we practice enough that we are not going to forget anything important. Um, Run each chief complaint with your mnemonic. Make sure you know how it would be modified to fit each chief complaint. And that's where I have a little extra cheat sheet that I'm going to share with y'all that has each chief complaint kind of broken down. Try to maintain eye contact with your patient. Do not just stand there and stare and write down all the answers, right? You want to engage with them. You want to make them feel comfortable and heard, right? So try to sit down, try to make eye contact with them, show them that you're not rushed. Don't stand by the door holding the doorknob asking them questions, right? You'll get the best information if your patient's comfortable with you. Um, at the beginning, kind of when you're introducing yourself, you can ask the patient how they would like to be addressed, so that you don't assume anything. I think it's usually safe to call a patient Mr. or Mrs. So and so, but just in case, or Mr. and Miss so and so, I guess, not to assume that they're married. But either way, if you'd like to ask them at the beginning, maybe they want to be addressed by their first name. That's another little tip. And last but not least, be professional, of course. But sometimes being professional can sound kind of robotic, where you're just like, "What is this? What is this? What is this?" Have a human touch to you. Be empathetic. Try to understand where they're coming from, and that will make you a better clinician. So, I'm done. I think I've talked your ear off here. I do hope that that my experience and my take on this might help at least a couple of y'all try to kind of wrap your mind around what it is to take a history of present illness. I do plan to follow up this video with similar videos on the past medical history, family history, social history, and review systems. So hopefully this was helpful. Let me know in the comments below if it was helpful so that I can make some time to make those other videos for y'all. As always, if you have questions, let me know, and I'll see you in the next video.